Reproductive pathology, penile pathology. All right, first and foremost, we have Peyronie disease, abnormal curvature of the penis, and it's secondary to the fact that we have fibrous plaque within the tunica albuginea. All right, that's it. Don't worry about it. They're never going to really ask you questions on it. Next is ischemic priapism. Priapism is painful, sustained erection, okay, usually lasting greater than 4 hours. If a patient comes in with an erection that's lasting 4 hours and it's painful, it's usually ischemic priapism. It's secondary to the fact that we cannot drain the penis, okay? So the penis is constantly erect due to the fact that it's vasodilated and the blood cannot leave, so there's venous obstruction. All right, so what can we treat it with? If it has impaired venous drainage, we're going to treat the patient with alpha-1 agonist to lead to increase in vasotone, vascular tone. So we can have vasoconstriction and the priapism can go away, right? Now, one drug that they love to talk about is trazodone. Trazodone is a drug that's used to treat insomnia, but it can have a complication of priapism, okay? The patient can present with priapism if they take trazodone, all right? So the way that they call it is trazodone causes trazobone, all right? That's like what they always say. Don't forget that you have block venous drainage of corpus cavernosum vascular channels, and that's what causes it. You could also see it with an increased risk with sickle cell disease patients because the sickled red blood cells can block the venous drainage as well. All right. For squamous cell carcinoma, I'm going to be skipping over that, relatively lower yield. Next is cryptocortism. Cryptocortism is a descent failure of one or both testes, and you have impaired spermatogenesis secondary to the fact that we have our Sertoli cells up within the abdominal cavity still because they haven't descended, and those Sertoli cells become dysfunctional because they're temperature sensitive. And since they're temperature sensitive and we're not in the scrotum that controls our temperature, then we have an abnormality with spermatogenesis. So we get subfertility in the testis that is within the abdominal cavity. If the other testis descends normally, then you're fine, okay? The patient will not have any problem. You'll have normal testosterone levels in a patient that has one testis that fully descended and one that doesn't, okay? It's associated, though, with an increased risk of germ cell tumor. The one that stayed within the abdominal cavity has an increased risk of germ cell tumor specifically, okay? And so you have to keep in mind that that's very important. We'll talk about it. It's called a seminoma, okay? You're going to see decrease in inhibin B production because one of those testes are still not functional. And you're going to have overall decrease in testosterone only when there's bilateral cryptocortism, right? There's normal levels in unilateral because that one testis will do the job of both. So keep in mind, decrease in inhibin B because you have decrease in Sertoli cells, which leads to an overall increase in FSH for cryptocortism. And that seminoma is very important as well, which we'll talk about later. Next is testicular torsion. You'd be surprised at how high yield testicular torsion is. So what happens is that we have the rotation of the testicle around the spermatic cord and the vascular pedicle, okay? That's going to lead to decrease in blood flow from the gonadal artery, okay? Which gets its blood, by the way, from the aorta. So it goes directly from the aorta to the gonadal artery to the testes. If you rotate around it, that means you decrease the blood flow. The patient's going to have an absent cremasteric reflex. And the cremasteric reflex is just when you stroke the inner side of the thigh that causes a rise of the ipsilateral testes. Okay, so you're going to have an absent cremasteric reflex in the testicle that is torsed. Okay, this is usually secondary to an anatomic defect. Okay, it's due to the fact that we have an increase in testicular mobility in these patients. So they have twisting around the spermatic cord, right? And it's due to an anatomical defect. It's the increase in testicular motility is the cause. Okay, so usually when we go in to fix a testicular torsion, we're going to cement them to the ground of the scrotum, and you have to fix both of them because the anatomical defect is not only in the one that was torsed, but it's in both of them most of the time. Okay, you have to fix both, and that's known as orchiplexy. All right, now the patient's going to usually present with like severe acute pain. All right, if they have random severe acute pain while like playing soccer or playing some type of sport, then you know that you're dealing with some type of testicular torsion, and that's what they're pointing you to. It's usually in children that are like 12 to 18 years old. Okay, so keep that in mind. Absent cremasteric reflex, and they call it the bell clapper deformity because the way that the testis sits looks like a bell, okay? Next is varicocele. Varicocele is just the dilation of the veins in the pampiniform plexus, all right? And that's due to an increase in venous pressure. The question is, what's causing the increase in venous pressure? Most often, it's on the left side. The reason behind that is because when we drain from the left gonadal vein, we have to drain into the left renal vein before we go to the IVC. So that leads to an increase in backup potential, okay? So that's why we will mainly see varicocele in the left side because of the increase in resistance to flow from the left gonadal vein draining into the left renal vein. If you see right-sided varicocele, it indicates that there's an IVC obstruction, specifically could be potentially from renal cell carcinoma or clear cell carcinoma. All right, so we'll rarely ever see a right-sided varicocele. If there is right-sided varicocele, because remember, the right side gonadal vein is just going to go drain directly into the IVC. But if there is a varicocele on the right side, that can indicate a renal cell carcinoma. Okay? Now, how's the patient going to present? The patient's going to present with, once again, on physical exam, we're going to ask them to do Valsalva maneuver, and you can palpate bag of worms, okay? So if we diagnose it by the Valsalva maneuver, and the way that we remembered it was Valsalva for varicocele, so V and V go together, and they love to ask that question. You're going to feel distension on inspection, and they're going to have a bag of worms on palpation, okay? Augmented by Valsalva. You feel it more when the patient has a Valsalva maneuver, okay? It does not transluminate. Now, a question that they like to ask is left renal vein can become compressed between the aorta and the superior mesenteric artery. And this is mainly in the GI section, but it's really important, okay? This is known as the nutcracker effect, okay? So what happens is, anatomically, we're going to have the left renal vein get smashed between the SMA, superior mesenteric artery, that supplies the blood supply to the gut, and the aorta. And when it gets smashed, it causes an increase in blood flow back up, okay, from the left renal vein into the left gonadal vein and causes left-sided varicocele, okay? And that is called the nutcracker effect. Once again, you're going to see the Valsalva maneuver. It's going to be really helpful. This increases your risk of infertility due to the fact that it increases temperature because, once again, more blood, that means that there's increased temperature with the blood because you don't have blood flow occurring, so that blood's just sitting there stagnantly, increasing the blood pressure, or increasing the temperature, I should say. All right, moving on, we have extragonadal germ cell tumors, okay? There's two types. We have hydrocele and spermatocele, and these transluminate. So if you ever see translumination, start thinking of either hydrocele or spermatocele. Okay, very important. Translumination, you might think, oh, who cares? No, translumination is hydrocele or spermatocele. All right, hydrocele is just accumulation of serous fluid within the tunica vaginalis. All right, very important. When you have communicating, that means it has fluid within the tunica vaginalis. That's it. And you have incomplete obliteration of the processus vaginalis, right? Now, what we love to talk about, something that everyone talks about, is that you have an increased risk of something known as an indirect hernia, okay? Specifically with a hydrocele, all right? Because we have the abnormal, or we don't have the obliteration of the processus vaginalis, you have an increase in risk in these patients for an indirect hernia. And we'll talk about that in the GI section, all right? Next is spermatocele. Spermatocele is just a cyst due to dilated ependymal duct or radiotestes, all right? That's really all that matters. So we've covered that all. Those are our penile pathologies with some of our testicular pathologies. Next, we'll talk about testicular tumors, and we should be done after that page when we talk about the prostate.